Okay, so we're going to get started. Hi, everyone. I'm Mary Catherine Beach, one of the core faculty members at the Berman Institute of Bioethics. Very excited to be introducing Diane O'Leary. She will be talking to us about diagnostic ethics, parameters for safe, ethically, and socially just management of medically unexplained symptoms. Diane O'Leary is a philosopher and bioethicist, a disabled independent scholar whose research crosses disciplines to consider mind and body in medicine. She has been a visiting fellow at major international institutions, specializing in the philosophy of science, philosophy of mind and bioethics, including the Center for Philosophy of Science at the University of Pittsburgh, the Rotman Institute of Philosophy in Ontario, and the Brocher Foundation in Geneva. She is also a member of the Primary Care Research and Diagnosis Errors Pride Learning Network, led by Brigham and Women's Center for Patient Safety Research and Practice. And Dr. O'Leary is currently at work on a book, Medicine's Mind-Body Problem, a Safe, Sound, and Readily Actionable Solution. So welcome, Dr. O'Leary.
Thank you. Really nice to be here today. And I'm particularly looking forward to talking with everybody after my presentation. So I'll just go ahead and share my screen. Okay, is that clear? You can see my slides and hear me okay? All righty. My talk today is going to be in three basic parts. I'm going to start with 5 simple facts about medically unexplained symptoms. Then I'll try and pin down the problem with the current model along 3 kinds of parameters. Then I'll try to offer an alternative that's grounded in ethics. First, 5 facts about MUS. Number 1, MUS are the most common symptom group. So there was this foundational study in 1989 that found in primary care, organic etiology was demonstrated only in 16% of cases. Since that time, prevalence estimates have varied widely because, of course, the term MUS is slippery. Your prevalence will depend on how you define it. So you can find estimates anywhere from 4% to 84%. Up to date, and the UK's National Health Service settled on an estimate of 50% of outpatient symptoms being medically unexplained symptoms. Fact number 2, MUS care generally fails to resolve symptoms. So these are the most costly symptoms in outpatient care, and patients are the least likely to benefit from all of this expenditure. Number 3, clinicians are very dissatisfied with MUS care. So doctors' most frustrating encounters are those involving patients with MUS. And this issue is a problem not just in the patient-facing side, but also in training. So GPs feel like their training is insufficient to equip them to deal with MUS. Of course, patients are very dissatisfied with MUS care. They feel their pain and disability are invalidated, and this often leads to a refusal to seek future care when care is needed. Stone has remarked that, Louise Stone that is, has remarked that patients often feel they have to fight for the right to access care. And that's an issue that's going to come up again in a little while. I think this patient's face is really a great expression of the way that patients feel in this area, and doctors as well. Stone has explained this as MUS create an environment of shared blame, shame, and hopelessness. And I think that's really accurate. Sorry, my slides are not advancing. Number 5, this difficulty in the exam room has spilled over into the public's relation with the medical profession. So the public is increasingly angry about the problem of MUS. And we started to see this in the media with this article in The Atlantic in 2018. The doctor doesn't listen to her, but the media is starting to, where we start to hear about gaslighting, doctors not taking symptoms seriously when they actually are symptoms of disease, primarily with women. In 2018, we get this hashtag on Twitter that was very unkind to doctors. I won't repeat it. And within a matter of days, 40,000 posts under this hashtag. expressing frustration with care in this area. To be clear, these are not stories of frustration about respect or validation or communication. These are patient stories about error. So there are stories where patients go to see the doctor, they explain their symptoms. The doctor says, oh, that's psychological, that's stress, that's anxiety, or they just don't take the problem seriously. Then patients go somewhere else later, find they actually suffered from disease, and they're very frustrated about that. So the following year, 2019, we get another one of these hashtags, this time 60,000 contributions. Also patient stories, just this endless tens of thousands of patient stories. Of course, all of this went away in 2020 with COVID for a while. We stopped seeing this kind of thing in the media, but then long COVID arises, and as this commentary points out, pits patients against doctors. And once again, we're talking about gaslighting, not taking symptoms seriously, concerned that there's the disease that's not getting treated. So the issue arises again. And of course, this is going to continue to be a major discussion in the media. The long COVID issue has, of course, kicked off the whole gaslighting conversation in the media. We get this article just 2 weeks ago, how to navigate medical gaslighting. And this time media is no longer asking, is gaslighting an issue? Is there a problem here? The small print here says, providers don't always take patients' concerns as seriously as they should, as if that's now an established fact. So we're back to this conversation, and now it's even more emphatic than it was before. And this is not going to go away, I think. So if our current approach to MUS care had failed on any one of these levels, I think we would say it's not working. It has failed on all 5 levels. So I think it's clear that this approach is not working by any standard. Before I dig into the source of the problem, I just want to say right off the bat, I do not think doctors are the source of the problem. So I'm not going to spend the next half hour saying all the things doctors are doing wrong. I don't think that's the nature of the trouble. Clinicians trust their training in good faith, and they should. They assume that medicine's model for MUS care is rigorous and safety tested, vetted for ethics, vetted for social justice. Unfortunately, that is not the case. What I'm going to suggest is that doctors are not doing anything wrong. Patients are not doing anything wrong. The source of the trouble here is the model. There's no way for clinicians to practice based on this model and have care be successful. It's just not, it's not a model that can work. Okay, so I'm going to try and pin down the source of the problem here. And first I'll talk about safety. That will take the most time. Then I'll talk about ethics. Then I'll talk about social justice and move on to what seems to me to be a good approach to trying to fix this problem. 2 issues arise in the safety area. One concerns ambiguity, the other concerns error. On the ambiguity point, the term MUS, as I said, is very slippery. So sometimes the term is used to mean undiagnosed symptoms, so symptoms that have uncertain causes after diagnostic effort. And broadly speaking, of course, undiagnosed symptoms can have 3 kinds of causes. They can be just benign self-limiting symptoms that will go away. They can be symptoms of unrecognized disease, or they can be psychosomatic symptoms, that is, bodily symptoms that are caused by psychosocial distress. Unfortunately, much of the time, the term MUS is used to mean psychosomatic symptoms, just the third option here. So the term medically unexplained symptoms actually doesn't allow us to distinguish between cases of uncertainty and cases where, well, we were uncertain, but now we know that symptoms have psychological causes. So this causes a real problem for patient safety. Because we use the same term for diagnostic uncertainty and psychosomatic symptoms, clinicians actually don't have criteria for deciding that symptoms are psychosomatic. That's a really big problem. At the same time, because we are using the same term for both of these things, it becomes extremely difficult to see or discuss error in psychosomatic diagnosis. And that leads us to the second problem. As I'm going forward, I'm going to stop using the term MUS because it is so ambiguous. So I'll either say undiagnosed symptoms or UDS, meaning symptoms with uncertain causes, or I'll say psychosomatic symptoms, or symptoms that are determined to be primarily caused by psychosocial distress. Okay, on error, in addition to the lack of criteria for diagnosis, and in addition to the terminological difficulty of even seeing error, clinicians are routinely informed that their ability to spot psychosomatic symptoms is essentially infallible. In practice recommendations around MUS, extraordinary confidence is recommended. So you often see recommendations like this that state the misdiagnosis of a serious medical disorder as psychosomatic is fortunately rare. In the Oxford Textbook of Medicine, for example, in the MUS section, they do find a way to discuss error, which is actually really difficult to do with this terminology. And they state directly that clinicians should trust their intuitive determinations on psychosomatic symptoms because error is rare. Is that true? Is error actually rare in this area? Well, the difficulty there is that the studies that examine error are not focused on patient safety. So we really do not have any science to support the conclusion that error is rare. One large study in 2001 found that in secondary care, patients with disease had often been misdiagnosed as psychosomatic previously. So in gynecology, 28% of patients with a disease diagnosis had previously been mistakenly diagnosed as psychosomatic. In rheumatology, the finding there was really alarming. 50% of patients who have a disease diagnosis in rheumatology had previously been diagnosed as psychosomatic. So they spent a period of time in need of medical care without getting medical care. So this is a very concerning finding when it comes to patient safety. You would think that these findings would lead to discussion of error, research on error, revision to practice recommendations so that clinicians can be aware of this kind of error. But none of these findings made their way into recommendations because they were buried in an article that was focused on the opposite error of mistaking psychosomatic symptoms for symptoms of disease. So these findings never had any kind of impact. In 1965, a psychiatrist in the UK at Maudsley Hospital, very prominent, highly respected psychiatrist, had a kind of a personal reckoning about diagnosis of hysteria. He had diagnosed a great many patients with hysteria. He came to feel concerned that he'd made a mistake, that many of his patients were actually suffering from disease. So he actually went in there and reevaluated the cases of 85 hysteria patients in an effort to vigorously search for disease, and he found it in 60% of patients. There's a lot of dispute about how to read those findings, but it's generally accepted that he concluded that he found it in 60% of cases. On the basis of this kind of finding, Slater really launched a kind of campaign against psychosomatic diagnosis. He concluded that hysteria is a delusion and a snare. And in my most favorite quote in all of the research in this area, he says that hysteria is a disorder of the doctor-patient relationship. So these findings launched a whole lot of studies on error since Slater's time in the field of psychosomatic medicine. And these studies have claimed to show that the error rate has steadily been reduced since Slater's time, all the way down to the astonishingly low level of 4% currently. And generally speaking, the rate of error, diagnostic error, is understood to be between 10 and 15%. So 4% would just be an extraordinarily low amount of error. The thing is that the method of these studies is just not comparable to the method that Slater used. And in fact, the method of these studies does not support any conclusion about the rate of error. These studies do not return to patients' cases to vigorously search for disease, as Slater did. Instead, these studies just review records. So what they determine is the rate at which doctors are willing to consider the possibility of error and pursue it and do some more tests, and then they find the test and then they overturn the diagnosis. But of course, nobody likes to imagine that they've made a mistake. In this marvelous paper by Berner and Graeber called Overconfidence as a Source of Diagnostic Error, really terrific paper, they say that the concept that they personally could err at a significant rate is inconceivable to most physicians. So they estimate that 1%, physicians imagine that they make an error in 1% of cases, when in reality, the error rate is 10 to 15 times higher than that. But I don't think physicians are any different from anyone else, actually, in this regard. Everyone is overconfident. In any case, this kind of a study is not going to give us an error rate. This is going to give us a rate at which doctors are willing to imagine that they've made an error and pursue it and find an error. But of course, that finding will be much, much lower than the actual rate of error. In reality, if Slater's findings were accurate, then these findings of a low willingness to pursue error are actually very concerning about error. They should in no way alleviate our concern about error. So, like the terminology in this area, the error research is just not attentive to patient safety. And I think this is why the public is angry. The public is angry about safety, because I think most people know someone who has experienced this kind of problem where they have symptoms, they go to the doctor doesn't take them seriously or attributes them to the psyche, and then it turns out they suffer from disease. I think most people know someone who's experienced that kind of problem, and most people do have the sensibility that medicine is unconcerned with this, that doctors are unconcerned with this, that it's very hard to communicate about this in the medical setting. Disease organizations pursue this kind of concern often. So I work with a lot of these organizations, talk to a lot of these patients. I'm not going to go through the whole list of them. Honestly, I could spend the entire talk just listing all the patient organizations who have expressed concern about mistaken psychosomatic diagnosis and its problem for patient safety, the harm it causes to patients. The important thing is that each of these organizations pursues this issue independently. So it's not as if they all work together and say, yeah, there's a problem, let's sort it out. They come to this conclusion independently. So half of patients with autoimmune disease report that they've experienced this error. Patients with endometriosis, extremely long diagnostic delay, which they attribute to clinicians not taking the problem seriously. In rare disorders, the 7-year average for diagnosis, according to the Global Genes Project, studies establish a tie between psychosomatic diagnosis and delay in diagnosis of rare disease. Rare disease is not rare, by the way, collectively. Rare patients with rare disease are as common as patients with diabetes. And Ehlers-Danlos syndrome, the vast majority of patients report that they've experienced this kind of error. None of this evidence has been considered in research on error in psychosomatic medicine. So none of this material makes its way into practice recommendations. And it is in this sense that clinicians are not at fault. The recommendations continue to tell them that they never make a mistake. We don't have science to support that. And all of the evidence that we have that that's actually inaccurate never makes its way into recommendations. So on the safety issue, extraordinary confidence is recommended. There's no clear terminology. There are no criteria. There's no rigorous study of error. You have strong public concern in all of these areas. I think that when you have this disparity between public concern and professional attention, it really is the role of bioethics to step in and try to facilitate some kind of solution. So, okay, I'm going to shift over now and talk about the ethics problem. And really, I want to start with an intrinsic challenge to practice in this area that is not related to the current MUS model. People generally respect one another's authority on whether bodily sensation is present. So if I tell you I have a backache, you're not going to say, no, you don't, unless you think I'm lying, because you'll know that you can't feel my back. Only I can feel my back. You can't say, yeah, I feel your back and there's no pain there, right? Medicine reflects this same respect when it asks patients how they feel, because it recognizes patients' uniquely reliable knowledge of the body. But when symptoms are diagnosed as psychosomatic, this respect disappears. You no longer respect a person's unique knowledge of the body. And this disrespect occurs even when the diagnosis is accurate. Psychosomatic diagnosis says that the doctor believes she has better knowledge of the patient's first-person bodily experience than the patient has. This always leads to an affronted feeling on the patient's part, a sense of disrespect. And this is just an intrinsic problem with this kind of a condition, even when the diagnosis is accurate. So to address this problem, the current model from psychosomatic medicine has advised that clinicians shouldn't tell patients when they decide that symptoms are psychosomatic. Instead, they should use etiological neutrality or ambiguity, where you use a vague mind-body language to kind of obscure the diagnosis so that patients don't get mad and leave, cause a big fuss, fight about it for a long time. And I think clinicians trust in good faith that this practice, this compromise to truth-telling, is humanistic and patient-centered and ethical, because these terms arise a lot in this area of medicine. In reality, it is none of those things. It is not humanistic or patient-centered or ethical, I think, for clinicians to routinely mislead their patients. In the field of psychosomatic medicine, I think it's safe to say that the majority of research for the last 30 years has focused on what I think of as deceptive ingenuity. So this is not just an offhanded recommendation. There's been extensive research on the terms that will best mislead, the settings that will best mislead. The practice of deception is a very intricate and advanced, the result of very intricate and advanced research on how to deceive. So the term functional, for example, was found to be advantageous because it will mean one thing to clinicians and another thing to patients. Of course, this is going to raise the question of informed consent, because if patients are unaware of psychosomatic diagnosis and they're unclear about the goals of their treatment, it's unclear whether they're giving informed consent to care. And if this is occurring in 50% of cases, as we see in sources like UpToDate, it's standard practice to deceive this often, to mislead about the nature of treatment, then it seems clear we have a substantial problem with informed consent in everyday outpatient care. Sorry, my clicker is not working. Here we go. The question we need to ask then is, what makes it seem okay to clinicians to deceive patients about, I mean, aside from the fact that patients fight, and that's very unpleasant, what makes it seem okay to compromise truth-telling, informed consent, and autonomy with this patient group? On that, here's a foundational paper from Professor Sir Simon Wesley, who's important to the field of psychosomatic medicine still. He presents us with this standard case where the patient says, well, is it all in my mind? And if the doctor tells the truth, the patient will leave. Then here in the second paragraph, he says, it's for these reasons that my colleague once called hysteria the H word, the diagnosis that dare not speak its name. Not incidentally a diagnosis that has disappeared. The study suggests that it is indeed a tough old bird, some terrific language there, that has continued to outlive its obituaries. It is still around, but never spoken about, at least not to the patient. So I'm going to suggest that the reason why it seems okay to mislead these patients, because they are actually understood to have hysteria. Hysteria is obviously a women's condition. It's been understood that way forever. And up until recently, in 1970s, say, women were not respected as autonomous decision makers. So misleading these patients, denying informed consent, this kind of thing seems okay because these patients are not understood hysteria patients historically have not been understood to be autonomous decision makers. In its Victorian heyday, hysteria could involve undiagnosed symptoms, too much interest in sex, lack of interest in sex with husbands, lack of interest in raising children, any other behavior construed as immoral. And these are not different varieties of hysteria, really. These are one condition. So when patients suffer from undiagnosed disease, they were diagnosed with a sexual condition, a moral condition. And of course, we know that lupus, MS, and endometriosis were routinely diagnosed as hysteria. So women with these diseases were subjected to treatment, recommendations of sex to husband's liking, recommendations to have children, sometimes clitorectomy, sometimes moral training, often involuntary commitment, because of course, patients were not asked for consent to care for hysteria. I think by any standard, these are profound injustices, and they clearly were perpetrated on the basis of gender. Hysteria was never rejected by medicine. Instead, in 1980, in DSM-3, it was renamed for deceptive purposes. So here's a preface to a textbook. Hysteria was renamed by committee and now masquerades under these DSM terms of somatoform disorder and somatization. The change of name reflects the fact that patients with these chameleon symptoms come to the clinic for the comfort of diagnosis, as long as the diagnosis is not that of hysteria. So this idea of lying to patients with these kinds of conditions gets instituted here in the DSM-3 just as a normal part of practice. In 2008, leaders in the field of psychosomatic medicine came together to publish this paper to suggest that the disappearance of hysteria is an illusion. Anybody who thinks hysteria disappeared with Charcot doesn't know what goes on in the clinic. And to be clear, they never mention in this paper historical injustice to women. They encourage clinicians to bring the concept of hysteria back into everyday practice, and yet they never once mention obstructed access to medical care to women with disease. Hysteria is thriving in practice recommendations from psychosomatic medicine. The current construct in the DSM, the central construct for psychosomatic symptoms, is somatic symptom disorder. If you go to Medscape, which is the #1 online source for information for doctors, if you go to the entry on somatic symptom disorder, you find the statement that clinicians should expect a ratio of 10:1 of women to men in diagnosis of somatic symptom disorder. So the recommendation there is diagnose women as psychosomatic 10 times more often than men. American Family Physician makes that very same recommendation. You think, okay, what is the source for that extraordinary disparity? And it turns out Medscape cites American Family Physician only. American Family Physician cites Medscape only. Neither one of them see any need to provide science to support that gender disparity. I think this makes it clear that the problem of MUS is a social justice issue. These kinds of recommendations clearly will lead to gender inequity in healthcare, because what they're telling clinicians is that women need medical care, women who seek medical care need it 10 times less often than men, right? And that obviously is false. Women don't need medical care less often than men. In fact, it seems we have evidence that they need it more often. This lack of caution arises from the grounding model of hysteria in psychosomatic medicine. That model has never been evaluated in terms of healthcare justice for women. Okay, so our current approach to MUS care, to care of undiagnosed symptoms, is misguided in 3 ways. On safety, MUS care is unsafe because it's based on bad science. Faulty terminology makes error likely, then low quality research ignores evidence of error. In ethics, care fails to respect autonomy because it's centered on deception and open to compromising informed consent. On social justice, MUS is hysteria in disguise, but there has been no effort to address or avoid the legacy of gender-based harms in the name of hysteria. So I'm going to suggest that we can do things differently. I just love this picture in this context. We don't need to keep trying to make this model work. This model has failed on so many levels. I really don't see any way to redeem it. And we certainly cannot rely on the field of psychosomatic medicine itself to repair things. If we abandon the idea of MUS and all the practice standards that go with it, we can build a new way of doing this that actually works. I mean, change is difficult, obviously, and there are a lot of very highly respected professionals invested in this model. So, change is hard, but I really don't see any reason why we should continue to do things this way. My sense is that, in the cases of diagnostic uncertainty, some symptoms are benign and they're going to pass. Some are caused by disease. Some are caused by psychosomatic symptoms. So only a part of the undiagnosed symptoms belong under the purview of psychiatry. And for this reason, I think it's clear that psychiatry is actually not the right foundation for management of diagnostic uncertainty. I mean, when you look at it in the big picture, I mean, at no point in the history of medicine did someone say, cases of diagnostic uncertainty are difficult. Why don't we hand that over to a small area of psychiatry, right? Nobody ever made the decision to do that. It was this sort of happenstance that it worked out that way. But I think it's clear that this little area of psychiatry should not have this big a role in everyday medical care. It just doesn't have the facility, doesn't have the tools. This research is not reviewed in the context of medical safety. It's just not going to work for psychiatry to be directing care in this area. Cases of undiagnosed symptoms are cases where biomedical science doesn't light the way forward, doesn't tell clinicians what to do next. Cases of uncertainty. Psychiatry is not equipped to fill this gap. So I'm going to suggest that in these cases, clinicians should rely on ethics. It's clear, I think, that patients with undiagnosed symptoms have a right to scientifically cautious healthcare, just as everyone else does. They have a right to respect for autonomy, to truth-telling, to informed consent, just as everyone else does. And of course, they have a right to gender equity, just as everyone else does. I think that these constraints are enough to guide practice, to serve as a foundation for a different way of approaching diagnostic uncertainty. I'm going to offer now 5 principles for ethically guided care of UDS, undiagnosed symptoms. I'm going to walk through each of these and then we can talk about them. First, and most importantly, I think the way to do this is to begin by normalizing diagnostic uncertainty in medical education so that clinicians come to expect it as the most common result. In this way, we eliminate the shame of not knowing what's causing symptoms, and ultimately this will lead to patients coming to expect uncertainty so that we no longer have this effort to avoid uncertainty and this urgency to settle on conclusions that aren't supported. So in order to do this, we would need to establish diagnostic coding for undiagnosed symptoms, UDS, preferably in a way that doesn't lead clinicians to get paid less. And of course, sharply distinguish undiagnosed symptoms from psychosomatic symptoms so that we can keep track of the difference and be clear about what we're doing with each of these different kinds of situations. So the term undiagnosed symptoms means that these 3 possibilities remain open. Symptoms could be benign self-limiting symptoms, could be symptoms of unrecognized disease, they could be psychosomatic symptoms. So this conclusion of undiagnosed symptoms includes all of these 3 things. For that reason, psychosomatic symptoms need to be excluded from the differential that leads to the determination of undiagnosed symptoms. That means that the decision to bring diagnostic effort to a close for the time being should be made entirely on the basis of biomedical science, including benign self-limiting symptoms, without consideration about psychosomatic symptoms, without consideration about gender. So in cases of uncertainty, you explore the diagnostic options, you come up empty, you don't have an answer. When you make the conclusion that symptoms are undiagnosed, you need to eliminate reasoning about psychosomatic symptoms. You need to eliminate the idea that women are more likely to have psychosomatic symptoms, get rid of all that, make the decision purely on the basis of what science does and does not tell you. In order to do this, of course, we're going to need some research on bias, because it's clear that determinations of medically unexplained symptoms are heavily influenced by race, by body weight, socioeconomic status, presence of mental illness, cultural differences, personality traits, likability. Like gender, none of these factors protect anyone from disease. So the determination that symptoms are undiagnosed needs to be made independently of all of these factors, purely on the basis of biomedical science. Second, and this one is radical, I think clinicians should stop diagnosing symptoms as psychosomatic. I'm not suggesting symptoms are not psychosomatic. I'm suggesting should not make this kind of diagnosis in medical settings anymore. The fact is that we don't have criteria that allow clinicians to make this determination safely, and that is after 40 years of effort from the field of psychosomatic medicine. We also know that when clinicians make this determination, they have to either engage in unethical deceptions or face the patient's wrath and the possibility that the patient will disengage. Neither of those paths are productive. I think it is more productive to just allow the question to remain open. On this point, we get some very good advice, surprisingly, from Freud, who pointed out that patients can only benefit from psychosomatic diagnosis when they discover it for themselves. He suggests it would seem that the pathogenic ignorance of the patient could be cleared up in short time and without much trouble if the clinician just tells the patient that symptoms are psychosomatic. If only that were all, he says. The physician can gain no results by transferring his knowledge to the patient in so many words. Knowledge of psychosomatic symptoms must be founded on an interchange in the patient, which can be attained only through psychic labors. Now, I think once symptoms are determined to be undiagnosed, the thing to do at this point is just to tell the truth. Clear out all the deception. Tell the truth about what is and is not known. Explain to the patient that undiagnosed symptoms are as common as all diagnosed symptoms combined. This is not an unusual conclusion. Explain all the diagnostic options that remain, including benign self-limiting symptoms and psychosomatic symptoms, and explain the scientific merits of wait and watch over continued testing. From that point, I think the best approach is to empower the patient to make her own determination about psychosomatic symptoms in a proactive way during the wait and watch period where symptoms are undiagnosed. Taking this approach, the disrespect of psychosomatic diagnosis shifts, becomes a genuine expression of respect for patients' autonomy. The need for deception is entirely eliminated. Trust is created on both sides, and the conflict that's characteristic of MUS care just dissolves. Of course, in order to make this work, and this is a big ask, obviously, this is a formidable challenge, something really hard to do, we would need to create a route for patients to pursue the possibility of psychosomatic symptoms from an authoritative and autonomous perspective. We would need to create a route for patient-driven mental health exploration. And I think it would be optimal for this to be incorporated into outpatient care. The UK has a program like this called the Improving Access to Psychological Therapies program, where MUS care, mental health care, is provided within the primary care system. But I need to point out very clearly that I am not recommending that we implement this program. If you wanted to find an example of unsafe, unethical, unjust management of MUS, this program would be the best example you can find of all of those kind of problems. What works about it is that psychological approaches to health are incorporated in the primary care system. If we follow that kind of approach, patients could choose to pursue this kind of self-exploration while symptoms are unexplained. And that kind of therapy really would only work if patients were genuinely empowered so that they remain the ultimate authority on psychosomatic diagnosis through the process. Okay, so there we go, 5 principles: normalize diagnostic uncertainty, stop diagnosing symptoms as psychosomatic, tell the truth about what is and isn't known, empower the patient to make her own determinations about psychosomatic symptoms, and create a route for patients to do that through a patient-driven form of mental health care that does not exist yet in any form. In short, the current approach to undiagnosed symptoms is unsafe and unethical and socially unjust. So care for undiagnosed symptoms should be driven by ethics, by a proactive concern to protect patients' rights to safe and ethical and socially just healthcare. Okay, really looking forward to the discussion. Thanks very much.
Thank you so much. I just want to tell everybody you can put your questions in the chat or in the Q&A box. You can also raise your hand, and I will try to monitor all of those things so that if you raise your hand, we can unmute you to make your comment or ask your question. So I found this fascinating, especially as someone who has experienced medically unexplained symptoms and someone who has seen many patients with medically unexplained symptoms. And I think back to a couple of things. One is that I've often thought I was explicitly taught in medical school that what people tell us is just unreliable. So, I mean, I was explicitly taught that. So I think that, you know, it's possibly not surprising if that's what we're taught, that doctors tend to not take people seriously when they report symptoms. And I guess I do think that there's a serious lacking on our part in not dismissing people. I think that we very much too easily dismiss people, and you've shown that, and people say that all the time. And I think that there's an incredible testimonial injustice just that we have, like physicians have, towards patients, that just this idea that patients are unreliable is promoted. And so there is some injustice in that. And I'm wondering then, like, because I'm so on board with that, I have one concern about your idea that I'm finding myself surprised that I have this concern, but your idea that we would not ever consider or diagnose psychosomatic symptoms, because what if there are, I feel like we might be doing a disservice to people who have psychosomatic symptoms. Mm-hmm. So I guess I just wonder, can you speak to that at all? And you know, what I don't necessarily think it's disrespectful mm-hmm. to think people have psychosomatic symptoms if they do. Yeah.
No, I entirely agree with you. There's nothing disrespectful about it. There's nothing shameful about having psychosomatic symptoms. And so there's nothing shameful about telling the truth about that. However, it's not possible for one person to tell another person that without offending them. Because in every case, you're saying that your knowledge of your own bodily sensation is faulty, mine is better. And yeah, in some cases that may be accurate, but in the medical setting, there's no way to communicate that without creating this offense. So I think it's really interesting too, and very helpful that you're seeing this explicit directive to assume that patients are unreliable reporters, this what you call testimonial injustice as like a general problem in training and in practice. And then also being worried that in cases where patients do suffer from psychosomatic symptoms, it seems important to address that. I guess what I'm suggesting is that I agree with Freud in this one limited way that there's nothing, it is not possible for that to be a productive determination from a clinician. There's no scenario where a clinician relays that to a patient, the patient goes, oh, okay, all right then, right, that's never going to happen. The only things that occur when that happens is that either the patient gets mad or the clinician misleads. And I don't think either of those are helping anybody.
There are, we'll follow up on that afterwards, maybe if we have time. There are two people with their hands raised and some questions in the chat, but I feel like we could explore whether there are ways of communicating that, because I feel like if you don't communicate, if you think someone has psychosomatic symptoms and you're not telling them, then you're either stuck, you're lying to them, which we're advocating not doing, or withholding it. So
yeah, well, you're right about that. I think what I'm suggesting is a very radical form of humility, an acceptance that we actually don't have criteria to make this reliable. We have tried for 40 years to develop these criteria. We do not have them. We have this enormous public concern about error. So there is no case where a clinician feels sure about it and we can actually trust that it's true. For that reason, anyway, okay, let's answer some questions. We'll talk about that.
Okay, I'm gonna, if Hannah is available to speak, she's got her hand raised and I think has a follow-up point on this issue. I think, Hannah, you should be able to speak now if you unmute.
Hear me? Can people hear me?
Yeah.
Yes.
Is my video on? I'm happy to have it on if it's not.
It's not on.
Oh, it's not on, but I can hear you.
I'm so sorry. I don't know why. I'm Mary Catherine, you know me, I'm terrible at this. I can't get my video on, but I will stop wasting time and speak. Thank you so much for the talk. I wanted to follow up. Okay, hang on. There, I think I'm okay. Hi, it's nice to see you. Thank you. I wanted to follow up on Mary Catherine's question because I guess I was really concerned, although of course I completely agree, it's terrible when diagnoses stem from gender-based oppression and stereotypes. I guess I'm skeptical that that's the only problem going on here. And I'm also, I guess, skeptical that there's no way of speaking respectfully to a patient about this diagnosis, which isn't to say that people need a lot of training they don't have, but nonetheless, I think in principle it could be done. And here's why. It seems to me that it's just not the case that in diagnosing someone with psychosomatic disorder, you are just in virtue of that, not crediting their first person testimony or undermining their authority. Mm-hmm. And the reason is that if you think of what the diagnosis is, it has to do with the attribution of an underlying cause for the symptom, right? Mm-hmm. So rather than thinking that it's based in some physiological process, the underlying cause is supposed to be based in a psychological process. And I do take it that patients, none of us can be authoritative about what the cause of our symptoms are. We can be authoritative about the nature and the experiential nature of those symptoms. Mm-hmm. It just seems to me that you could say to someone, and I take it this is sort of how it would be diagnosed anyway. Your symptoms are totally, I completely believe all your symptoms. This is not about discrediting the first person experience, but we can't find a physiological explanation. So one explanation we should consider is a psychosomatic explanation, right? That the cause here has to do with psychological distress that we don't yet understand. as opposed to physical distress. Because of course, then the mechanisms of treatment are going to be very different. So I guess my first question was just to sort of push back a bit that the disorder was inherently stigmatizing, because it seems to me it need not be if clinicians are trained in communications and framing it such that respect is maintained. But I guess the second more theoretical thing I was worried about was just the idea that there really could be a robust error rate here, because as I understand it, psychosomatic disorder is necessarily diagnosed via omission, right? So what happens is we can't find a diagnosis which is a standard diagnosis. And so then clinicians start to consider a psychosomatic diagnosis. And there's not sort of a clear way of diagnosing it, which confirms it, right? Which means there can't be a clear error rate. There's always going to be a certain amount of grayness here, because it may just be that although we've run all the tests we know about, there's another physical test or another physical disease that we haven't yet discovered that when we do will actually end up being the cause. So, I mean, I guess in light of that, for me, part of what I've always felt about psychosomatic disorder is that really what needs to happen is there needs to be less stigma around psychiatry and that disorder in particular. And that doesn't involve throwing the disorder out. It involves kind of taking much more seriously the kind of ethical concerns you have for patients who are wrongly diagnosed with hysteria and placing that squarely within psychiatry and within this diagnosis in particular. Yeah. So those are the three questions, right? Why does it undermine patient authority? Isn't it the case that an error rate would be impossible in any case? And three, how come fighting stigma in psychiatry in general and around this disorder in particular isn't as important?
Yeah.
As being concerned about gender-based oppression.
Yeah, these are really good questions, all of them. I think I should address first the stigma question. To be clear, the approach that I'm suggesting is meant to resolve stigma. The idea is that patients reject psychosomatic diagnosis because they don't find it for themselves. Freud was correct that there is no scenario where a clinician relays that and a patient says, oh, thanks, and it turns into a productive thing. That can't happen. It's only productive when the patient finds it for herself. So through this process, the clinician simply recognizes that we don't have criteria, as you say. And so instead of the clinician pretending that she can make that determination reliably, which she cannot, she instead empowers the patient to make the determination for herself, explaining fully that psychosomatic symptoms, as you say, you suggest, well, maybe we should consider this. This is exactly what I'm proposing. That the clinician says, well, could be these diseases that we haven't recognized, could be just benign symptoms that are going to go away, could be psychosomatic. This occurs all the time. I can't diagnose that in you, only you can diagnose that in you. So maybe go ahead and look into that and see what you uncover. In this way, the clinician stops suggesting that there's shame to it. The patient stops feeling that there's shame to it. And there's a route there for the patient to actually find psychosomatic diagnosis in a way that can actually work, that can actually be productive. In terms of the error rate, yeah, we can't discern an error rate, except it's really important to point out that all of these patient groups can't be wrong, right? Autoimmune disease, rare disease, endometriosis, vestibular disorders, now we have long COVID. In all these areas, you have all of these patient groups independently of one another insisting that they have a very serious problem with this error. I think that's really powerful evidence, and it's powerful evidence to know that that information has never made its way into the official research on error that directs practice guidelines. So that's really the most powerful source for concern about error, I think. Are we having other questions? I should stop then.
Yes, maybe Gail, if you're still have your question, I'm going to allow you to talk as well. You'll have to unmute yourself to do so. Gail, are you? Yep, great. You're muted.
Okay, you can hear me now?
Yes.
So I also want to really thank you for a really great talk on a very important topic. Like Mary Catherine, I've also experienced undiagnosed symptoms and experienced the horrors of the healthcare system in that regard. I have two follow-up thoughts to the discussion we've had so far. Two things that I think are just haven't been said yet that I want to say out loud. It's probably implied in what a lot of people have said. First, the issue of diagnostic error. You know, I think what's not typically said to patients is that certain chronic diseases take a while to manifest before they're diagnosable. So I think that diagnostic error is not exactly the right term in those cases, because I mean, that does put a lot of pressure on physicians. I think the error is that physicians are not trained to acknowledge that, you know, we can't find an organic explanation for your symptoms now, but it's that sort of wait and see approach that I think clinicians are not really taught to be comfortable with. But the reality is that many of these diseases do take a while to figure out. And it's that you know, that's different from saying we've made an error because we've missed it now. Yeah. The other point that I want to make is this link between undiagnosed symptoms and psychiatry. I think one of the faults that we make is that it's not unidirectional. We think, you know, the psychosomatic explanation, we think of it as psychosomatic imbalance causes the symptoms. The reality is that people with undiagnosed symptoms experience anxiety because of the symptoms. And so you can develop psychological distress or mental distress for having the symptoms for such a long time in an unrecognized way. So I think there's a role for psychiatry. It's just that we tend to think of the cause as sort of one directional, and the mind-body connection really makes it bidirectional.
I think that's really important. It would be so helpful if clinicians had that guidance regularly to think carefully about the bidirectional nature of it. I think also your point about error is really important. And what I'm proposing is that if we separate diagnostic uncertainty, undiagnosed symptoms, from psychosomatic symptoms very clearly, we can separate the problem of error in psychosomatic diagnosis from the problem of I don't know. Those are different problems, right? We need to have terminology that distinguishes them. We need to have different practices for them. Right, precisely for the reasons you say, because uncertainty arises and it persists, and you know, we need to develop ways of managing uncertainty where we humbly accept it.
We need to reward the acknowledgement of uncertainty in medical education and training.
Yes, good way to put it. Need to reward it. I'm with you on that. Yeah.
Great. There's one more minute, so it'll have to be quick. But Carol, if I allow you to talk, are you able to ask your final question?
Yes, there's Dr. O'Leary and Berman Institute. I just want to thank you all for this just fascinating talk and series. And I meant to actually put it to everyone, but I put it to the attendants. I will follow up, Dr. O'Leary, because I've been doing the notion of, and sorry, you said 1 minute and I've already gotten past that, but the engaged in community-based participatory action research in a particular project that I'm going on, that I'm involved in, that's going to lead to other things. Just really powerful of bringing folks together, of, you know, who's most often, especially because it's not just gender, it's all kinds of ways that folks are minoritized and are systematically facing epistemic injustice, and then that plays out in all kinds of other ways in terms of power with policing or healthcare or whatever. So thank you for a brilliant talk, and I look forward to talking to more people more about these issues. Thank you.
Great, thank you. Well, it is 1 o'clock. Diane should give you the last word, and we can end then.
I don't know last words. I think it might be time for a kind of workshop or conference, that there's an awful lot of interest in this area all of a sudden. And I think it might be productive to bring together all the different parties who have an interest in this kind of concern, and, you know, talk it out and try to find a better way of doing things. Anyway, thank you so much. Interesting discussion.
Thank you.